Good afternoon, everyone. My name is Adam Del Molino, and I'm the Senior Director of Virtual Care and Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, um, Demonstrating Value Through Data, Case Management Style. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end and throughout the presentation. I also want to take a moment now to thank MHA's 2024 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of many events we have on offer throughout the year to connect our members with leading experts and address timely issues like the one today. I'm pleased to introduce our speaker from the Center for Case Management today, Jeffrey Echternach. Jeff is a senior technology consultant at the Center for Case Management, and he holds nearly 20 years of experience in clinical systems, software, and business intelligence improvement experience. Jeff is the founder of the Center for Case Management's Cartboard Clinical Case Management Dashboard tool. Thank you so much for being here today, Jeff, as we are looking forward to getting started with this discussion. And I'd like to hand it now over to you to get us started.
Thanks, Adam. And it's a real pleasure to be here today. I'm going to start by sharing my screen, and we will kick off. All right. So today's talk, demonstrating value through data, case management style. It is a real pleasure to be talking to the Massachusetts Hospital Association members today, and I hope you enjoy selections from Statistical Duckery, which is a presentation we've given a couple times. And what I really like about this is we get to navigate a couple topics. We get to talk about data literacy, which is a really, really important competency that all case management programs should strive for. So let me be more specific about what we're going to go through today. I've tried really hard to take our learning objectives and weave them into the entire presentation. I am going to read this slide, but I'm going to do my best to not read many more word for word. Today, I want to make sure you all learn how to read and comprehend organizational data. I want to give you the opportunity to use data to demonstrate the value of case management to the team. Now, that could be the hospital team, that could be the entire organization, it could be the community at large. I'm going to give you some tools to review the process for building an ROI to ensure appropriate resources or provide new services. And we'll do some interaction in the chat here really soon. But I have two additional goals. Those would be to really share examples of data in terms of a value demonstration, and to show you key metrics that case management should master. Because we're in listen only mode, I am going to do my best. I'm a very interactive presenter. So I would love to hear your thoughts or comments at any point throughout this presentation by using the chat feature. And secondly, I will try to bring you into the presentation by inviting some specific question and answer that you can contribute to the chat. So, all right, with those kind of ground, those expectations set, let's dive in. So as I mentioned, setting the stage for today's talk, that first learning objective, it's all about data literacy. I like to be really specific about this 90 minutes we're going to spend together. And we are going to have about 15 minutes for questions at the end. So we really only have about 75 minutes. We're already doing math, in our time today. So we're going to talk about fun with math, 5 pitfalls. We're going to talk about how charts lie, which is a fantastic book by Alberto Kane. If you're a real data whiz like me, you'll enjoy that. We're going to talk about opportunities for case management data. That's your second learning objective. Therein specifically, we're going to look at demonstrating value with metrics. We're going to look at length of stay benchmarking. We're going to spend some time there. We're going to look at exploring data, and then we're going to do some real life examples of how case management programs actually unpacked problems in their organization with data and then translated an improvement. And then we're going to look at an ROI. We're going to do a length of stay ROI together. We're going to look at some DRG examples and really set a firm foundation or stage for what we can expect from DRGs and what we can't expect from DRGs. Okay, so let's dive into data literacy. So one thing that I think is really important is to let's unpack what that definition looks like and what that definition means, right? So data literacy is defined as the ability to read, to write, and comprehend data. What does that mean? It takes creativity to do this, it takes questioning, and it takes critical thinking. But there's a little bit more that I want to show you. If we are going to comprehend, we have to, in my opinion, decode what we read. We have to make connections with what we read and what we know from the past. And we have to think deeply about what we just read. This is part of a process that I want to offer to you as you consume new data, whether you are in a board meeting, a staff meeting, or you're just starting your day perusing your dashboard at your hospital or ambulatory clinic, wherever your practice might find you. This is the fun with math part. I hope you'll find this humorous. So first opportunity for interaction. I'm just going to ask in the chat if you'll send back your answer to the math problem on the screen. We've got 2 + 2, 4 + 5, and 1 + 5. Send in your chats. You are being baited, so I will warn you. The numbers are not as they appear. But I'm also going to prove that I'm not crazy. So I'm gonna show you how we got here. You know, sometimes we're in a boardroom, we're in an interaction, and we are looking at numbers. Maybe we're looking at our own hospital's length of stay, and we're questioning, asking ourselves, how did we get here? Why did the length of stay drop this month? Why did the length of stay rise? Well, on the screen, how does 2 + 2 = 3? I mean, that can't be right. And in some spirits, it's not right. But if we look at it this way, again, fun with math, and we just take those decimals a bit deeper, 1.53 plus 1.54 does in fact equal 3.07. So when we look at rounding errors, if we are perhaps baited into that first line of sight, that first set of numbers on the screen, and we don't pause to ask questions, to think deeply about what's in front of us, we might easily leap to a conclusion because we're in a safe space. We feel like we're ready to go to 2 + 2 = 4, and the numbers, you know, cascade on. So now we're going to have some more fun with math. I need to time this one because there's a fantastic author, Daniel Kahneman, who won the recognized in many ways for his contributions to math, to science, and this is going to really challenge your brain. So I'm going to advance the slide, and I'd like the members that are willing to participate, I want you to send in your response to the question on the screen, and I will read it just as quickly as you can. Okay, we're going to limit it to 30 seconds max. Here we go. A bat and a ball cost $1.10. The bat costs $1 more than the ball? How much is the ball? And because I read that out loud, answers in. So take a look at your answer. And I would be curious if you submitted that the ball is only 5 cents. And I'd also be curious how many of you all thought the ball was 10 cents. If the ball was 10 cents, then $1 more than 10 cents is $1.10. That math would not check out. So the bat is $1.05 and the ball is 5 pennies. $1 exactly different between the two is that confusing part, right? So sometimes we leap to the first conclusion that we see on the screen, because 2 + 2 = 4, right? But sometimes we have to, again, to truly comprehend that data, we have to slow down a little bit. We have to think deeply. We have to ask questions. We have to pause with intention. And now, no interaction for a few minutes. So keep keyboard at rest. It's not just numbers. I want to challenge that your children, your neighbors, your friends, and yourselves use data every day. You use visual data, grounded on a plane to give additional meaning. The example, I think and hope, will resonate. Of course, it doesn't resonate with, what is it, teenage boys, but nonetheless, we use visual data, visual cues to process information every day, which we'll bring back more visual examples later, but nonetheless. And I can't do a talk without spending a few seconds to just acknowledge my wonderful family of kitty cats that gives me a break from the day. So I will introduce you with this slide to my wonderful kitty cats that just really bring joy to me. And they make the cutest poses. We're going to see them a couple more times through the slides. So as I mentioned, statistical duckery can lead us astray. It could be 2 + 2 = 3. It could be a visual perception challenge with a graph or a dashboard. I mean, gosh, I'd love a couple chat messages on an example of a time that you in your practice got really just bad data, or a really jumbled together dashboard, just kind of a mess. And we'll talk more about it in a minute. Statistical duckery can lead us astray. So here's the thing. How can we be ready for that? Well, what I'm going to do is I've pulled my favorite selections from my slides on statistical duckery, and I want to introduce them to you today. So 5 pitfalls. I'm going to move through this quickly because we're still in our first learning objective, but I think that you'll find some of this humorous as well. And there's Emma in the background that I found one afternoon just sleeping in the bed, tucked herself in. Those cats are just too cute. We're going to do a poll. And if you'll just submit your responses. How many of the team members on today's call know how to perform CPR? And I'll give just 5 more seconds. So the question was, how many of you all know how to perform CPR? I'm not going to open the chat. I'm going to take the liberty of guessing that most everyone on today's call knows how to perform CPR. So now I will pose a question. Is it statistically valid if I publish just a quick Twitter post confidently announcing that 100% of the folks that are working in hospitals in Massachusetts, everybody knows how to perform CPR. Could I even go so far as to say that everybody in Massachusetts knows how to perform CPR? I failed to ask where everyone dialed in from today, but maybe you know where I'm going. This group may not necessarily be the appropriate representative sample to say that everyone in Massachusetts knows how to perform CPR. Now I'm going to show you a probably an inappropriate use of data. At least the UK thought it was so inappropriate that the UK told Colgate to take it down. I imagine some of us remember this, but do you know the story behind it? So Colgate sent out a survey and said, tell us the toothpastes, plural, tell us the toothpaste that you as a dentist would recommend. They went to 5 large area practices and said, just tell us the toothpaste that you recommend at your practice. And they got these responses back. Here's the challenge. While 80% of these dentists surveyed may have said Crest, 100% said, 100% said Crest. So while 80% said Colgate, you can look at the responses from the 5 dentists, 100% said Crest. So what are we looking at? These are all biases, right? These are all biases in how that data was obtained, how that survey was collected. I'll give you a bias example. Presenting length of stay for your hospital, but filtering out half of your units, or filtering out 2/3 of your units and not disclosing that in the length of stay statement. The second pitfall, reacting to common cause variation. I think we've all felt this before. You're in your case management meeting, everybody's pumped up. We've got 3 points in a series, and we tell the team we're on an upward trend, things are looking good. 3 points in a series may not, however, be that statistical. We gotta get our action plans ready. We're in a downturn. 3 points in a series. Things aren't looking too good. But we're gonna have a rebound. And again, with humor intended, 3 points in a series doesn't necessarily tell the whole story. So it's important to have an appropriate and, in many cases, a statistical basis to ground your theory, your proposal, your ROI, which we'll talk about. Pitfall number 3, averages. Now these are my 3 friends, the 3 amigos, the mean, the median, and the mode. All right, and I'm going to show you how we can use them in 2 very different ways to tell the exact same story. All right, here's your billboard. The average wait time is 57 minutes. All right, that could be true. That could be 100% true. Average wait time is 57 minutes. But this could also be true, because in this case, we look at what portion or percentage of all emergency visits are processed in less than 30 minutes. And essentially, we strip out the outliers, right? So in this case, there's probably a right-sided tail. There's a lot of cases that take very long to process. They might have data issues. Both of these can be true. So it's important that we, again, think deeply about the numbers that we're being presented. All right, pitfall number 4, statistical significance over clinical relevance. I think you'll enjoy this one too. So I want to introduce you to p-value. If you don't know it, p-value is a statistical assessment that we can use. It's again grounded in math, and it essentially looks at 2 sets of numbers or 2 sets of results and says, assuming there is no true difference, the p-value is the probability of observing what you saw or something more extreme. So we use this a lot in research and in testing and things like that. But you have to be aware of what we call a naked p. So here we go. A p result that's under 0.01 is potentially a fantastic result, because hey, that means you're getting published. That means that you're going straight to the journals. You might be on the presentation circuit. You might be picked up by a organization or a company. Okay, but if your p of 0.01 is the taco cleanse, and this is the intervention versus the control, what kind of a difference did you really make? Now let's look at another example. Here's the vegetable diet, the whole foods are an all natural plant-based diet with a p of 0.08. Not as confident. The p of 0.08 is saying that there may not be as much probability that you will always see the same results. And you can see here, the control was 1.2 pounds, but the intervention group that switched diets lost 15 pounds. Okay, p of 0.08. So what we say again is statistical significance over clinical relevance. Okay. Pitfall number 5, correlation does not equal causation. I think you'll also enjoy these. All right, so dinosaurs didn't read, and now they're extinct. Here's the correlation of ice cream sales to shark attacks. All right, so one might assume or propose an investment return or a strategy that forbids ice cream sales in the spirit of reducing shark attacks. Probably not going to work. Correlation is not causation. Here is trending of serum cholesterol values in men and women, looking at 2 life events, the birth of Justin Bieber and the introduction of Facebook. Correlation is not causation, right? Okay. So, and my favorite correlation causation story is the quantity of cars parked at the hospital parking lot does not necessarily predict your length of stay. Okay, there's Oliver making one of his cute faces. So now we're going to jump into how charts lie. We're still in learning objective 1. We're going to talk about how charts lie. This book is available for purchase. It is a fantastic book, but I have no financial interest in it. I just admire the text and the author. All right, so 4 cars are on the screen. We've got satisfaction results trended over a 5-year period for Chevy Ford, Toyota, and Nissan. All right, so Chevy, based on this graph, is a clear front runner. I don't know how that prints out, but they're at least what, a good 1/4 inch higher than the others. But okay, let's take a look at that axis one more time if we were to remove that adjustment. So that spread is from 95% to 100%. But when we consider that axis from 1 to 100%, you can see that these 4 vehicles are actually very closely tied or closely correlated with high customer satisfaction. So beware of a misleading graph axis. Please don't ever do this. I will say, please don't ever do this. And I am curious. So if you're willing to, send in a chat if you've ever received a graph that might be similar to this. I'll tell you right off the bat, the no-nos that I see. I acknowledge that Microsoft offers the ability for someone to do something like this, but we really want to try to make our graphs, our dashboards, and our presentations of data comprehensible in the 5-second range. Okay, the 5 to 7-second range. If it takes longer to get you don't necessarily have to comprehend all the data, but you need to be able to have a basic appreciation for what you're seeing on the screen. And what I can tell you is that this graph takes quite a while to familiarize with. And as I mentioned, the no-nos, we don't want to use 3-dimensional charts. We want to consider the relationship of the variables. And if it is a series, then we want to consider perhaps a 2-dimensional bar, maybe a stacked bar, something of that nature. But this graph is very hard to read. This graph is just plain wrong. Just plain wrong. And you can see the visual distortion that is challenging our users when we label each of the columns. So we label the columns with a numeric value, and then the graph or graphic does not catch up with us. Please avoid using pie charts. That's a Jeff opinion, although it's Alberto Keynes as well. And I highly suggest we don't do this. All I can really glean from this is that more than likely the witch costume was the most popular. But here's another consideration. When you're presenting data and you have over, this is probably 100 categories, but when you are reaching 7 to 10 to 15 categories, what I really think you should consider is how could those categories first be grouped? So how can we aggregate that data? And I'll give you an example. So we've got what we can read on this graph. We have witch, princess, pirate, cat, fairy, ninja, Power Ranger. The list starts to get smaller and smaller. But if we were to say, spooky creatures, fairy tale creatures, animals, cartoon characters, okay, that's may not be the best way to group it, but that's one way to aggregate that data into a slightly more meaningful categorization. Okay, so considerations for when you're displaying multiple variables. If you have not seen, this is a free website, DataViz Catalog. If you've not seen this before, I highly encourage you to take a peek at it. DataViz Catalog is really cool. What it will help you do is by asking you, the consumer, straightforward questions, it will help you navigate into what graph might be the best for the type of data that you're seeking to display. Another really cool thing this website can expose you to is it will give you some ideas about new graphs or graphics that you may not have seen before. The site is really thorough, so I encourage you to give it a look. And here we go. We have navigated learning objective number 1. I certainly hope you enjoyed learning objective 1. Now we're diving into learning objective 2, the opportunities that we have to use and to demonstrate the value of case management data. So, considerations. Most of this, I think you'll agree with me because you're in the business. Case management programs are covering the entire breadth of the organization. I remember a conversation I was having with an application analyst in an Epic system, and part of our conversation was about how many different security types they have to configure for case managers. And my response was, yeah, they're across the enterprise. They're in your Grand Central, bed placement, throughput. They're in your emergency rooms. They are in, of course, they're in your inpatient and observation areas. They're also in your rev cycle. They're also looking in your ambulatory, your post-acute. Sometimes they have the privilege of getting into scheduling, making sure that prioritized appointments for high-risk individuals are secured in a timely manner. They're everywhere. So, of course, their security is complicated. Case management touches nearly every service in the enterprise. You should have key performance indicators that measure the outcomes you are seeking and that your health system is seeking. Oftentimes, case management is positioned to move the needle for the organization on really key and very broad metrics. So when you look at your case management data, I want to suggest that you take an opportunity to reframe that conversation, whether it's in the boardroom or it is in the hallway during or after daily interdisciplinary rounds. You have the opportunity to reframe the conversation around length of stay, capacity, and throughput, moving the needle on certain key metrics, grounding that conversation with benchmarks and driving for specific outcomes. These are some suggested metrics. They are intentionally in broad categories on the screen. I will call out just a few that I think are very powerful. Many of us are familiar with volume metrics and length of stay. Length of stay has tremendous importance, and it really enlightens when you connect your length of stay with a valid, recognized benchmark. Today, I'm not going to go on record and encourage you to use one specific benchmark. There are several ways to benchmark your length of stay, and I certainly encourage you to look at how your hospital is benchmarking length of stay and really be an expert in how that benchmarking is taking place. Another really key area to look at is the referrals and post-acute transition. The MHA collects some really fantastic data from many of you on throughput and discharge transition barriers in your state. That wouldn't be possible without your data and systems contributing to the larger narrative. So that, again, I think is a beautiful illustration of the power of case management. Another call out, SDOH. I am sure that many of you were pulled into conversations, whether it was by quality, by IT, maybe, and hopefully you initiated the conversation when you saw the CMS regulations be updated for quality measurement, and more specifically, focusing on the collection of SDOH information for your populations. Avoidable days, one of my personal favorites. Avoidable days really puts the narrative in your hands, puts the narrative in your hands as case management leaders, and it's going to give you the opportunity to then unpack that narrative in multiple ways, including ROI. So now I want to just walk through length of stay benchmarking. So I have two blue bubbles on the screen intended to represent two unique patients, okay? Our first patient is going to be assigned a DRG. They are going to therefore have a acuity adjusted, or at least reasonably acuity adjusted benchmark length of stay. So let's say that for the population that we are comparing against, the tool and the data tool set that we're using, our first patient should have had a length of stay of 3.3 days. Now, you might say, well, Jeff, if you're using whole numbers, you can't have a 0.3. Yes, I acknowledge that. So 30% of the population should be out in 2 days, and 70%, excuse me, 30% in 3 days, 70% in 4 days. So in any event, you have a benchmark length of stay. So that's the benchmark organization communicating to you for this patient, for this DRG. That's your observed, that's your benchmark length of stay. And we're comparing against the observed. In the pink, we have what we call, or I'd encourage you call, an opportunity day. It's not an avoidable day because we haven't intentionally classified it into an avoidable day category. This is just math. Opportunity day is the delta between the benchmark and the observed. Another way of saying it, it's the O minus the E. All right. Opportunity days are O minus E. So if observed is 5 days and benchmark, or E expected, is 3.3, the difference is therefore 1.7. Second example. Observed length of stay was 5 days, totally different DRG. The benchmark was 6.5 days. In green, we have a negative opportunity day. We got this patient out faster than the benchmarking said the norm was. And again, that's not cause for concern. That's, in some cases, cause for celebration. Perhaps calculated celebration. We don't want readmissions, but there has to be a balance. Some cases are going to leave ahead of the benchmark. Some cases are going to leave behind the benchmark. It's important that we lean back and study our length of stay data in a variety of ways. And really, like my first slide said, develop a good, solid understanding of what that is trying to tell us. Where might the hot spots be located? How can we learn more about those hot spots? So I am again going to give you four examples. All right. So we've got 4 cases on the screen. We have the circumstances where the length of stay was better than the benchmark. Here are 4 of those cases. Now let's consider this. So if this is the performance in your length of stay data at your hospital, you're consistently creating enough bed space for an extra patient. So if you add up the green boxes on the screen, you might see it with me. 1.5 times 4, there's 4 patients on the screen, is going to create enough capacity, because that's 6 days that you've saved. Whatever the intervention was, that's 6 days that you've saved. So you're performing better than the prediction. You are creating extra capacity as well as cost effectiveness, cost avoidance, so to speak, in your hospital. So a slight pivot. I want to show you some examples of how you can display length of stay information on a dashboard and interpret it and really master that narrative. I strongly encourage organizations to use an overview explore method. Overview explore, I will have screenshots and show you what I mean, but to be very broad, the overview page is that high level snapshot. You can print it and you can run with it. You can distribute it with convenience to a wide audience, and you can get comprehension very rapidly. An overview page gives you that high level insight. On the other hand, an explore page like this can give you a lot of detail. So I'm going to jump back. On your overview page, I definitely would encourage that you look at the line graph on the right hand side. On this line graph, we are displaying month by month a trend over time. So we're displaying a time series of data. We have two colors, and we have graph or numeric labels on our graph, and we're layering the expected length of stay as an average for the org with the actual length of stay as an average for the org. So we're making that comparison at a very high level between the actual experienced length of stay and the benchmark. When the line is performing better or below the benchmark, you are beating the length of stay prediction, and that's cause for celebration. When the line is exceeding the benchmark, you are not performing as well as the benchmark would have suggested, and that's cause for investigation. Even when the entire org is performing at the benchmark or slightly better, there could still be problems brewing. So it's important to leverage committees and performance improvement commitments to explore your data. A tree map might be a new term for some, but a tree map is a graphical collection of information that can be color coded for a certain indicator, and it often uses the size of the population, whatever that population happens to be. In this case, it is hospital discharges, color shaded by their length of stay opportunity, where a pinkish red color suggests that there are patients exceeding the benchmark, and a green color suggests that patients are doing better than or beating the benchmark. So colors, a basic use of colors, can draw attention to areas that you want to focus on. We then take our data, and using a tree map, we subdivide our hospital, for example, by DRG, by unit, by hospital service, by origin location, by race, by first spoken language, by admitting service versus discharging service, cases that went to a post-acute, cases that didn't go to a post-acute. The list can go on for many, many days. And so, in addition, on your explore pages, having a variety of grouping details or abilities to choose different grouping variables is really important. Look at that second bullet point. What about my patients that come from outside the hospital? Are they longer length of stay, shorter length of stay? I heard that the hospitalist group is running a day over the benchmark compared to the internal medicine group. Is that true? Is it all hospitalists, or is it just hospitalist unit 1 or hospitalist unit 2? You know, have we always had delays in our length of stay getting somebody to a skilled nursing facility? Is that worse than an LTAC, better than an LTAC? Is it worse than an ARU? Is it better? All of these things are permutations that you can explore using grouping variables. So we're going to dive into some real life opportunities, how case management data is creating influence. And the first two examples come from your own hospital association. So you can see here a graph that is displaying specific, perhaps avoidable days or barriers, and using a relative weight to show the significance of that barrier by category against the total population that is exiting for a post-acute. Here you have a stacked bar that is looking at your discharge setting, so the setting that the patient is seeking transition to, that patients are not there yet. They're waiting. They've built up in the acute care system. What I like about this is it really can refine the focus. It also shows where that intervention might need to be made and where the intervention might need to be different. Now, I do think this data is rather consistent. It tells quite the story about skilled nursing facilities, but it also is telling an interesting story about Metro Boston's home health. And I'm not sure if you look at the other three categories, when we say compare the percent with delays to the total percentage discharged, I am guessing that the home health challenges in Metro Boston might be amplified, whereas it appears skilled challenges are consistent throughout the 4 regions. Good graph. I was able to analyze that in a few seconds. Here is a zoomed in version of a tree map. This tree map was used to drive length of stay changes at an organization. And let me show you a little bit of how they did that. So they put together a presentation for the Utilization Management Committee and pointed out different ways that the various hospital groups, the physician groups, could reduce length of stay. In this case, call it the carrot and the stick. They were encouraging the hospitalist groups and other physician practices to reduce length of stay, but they were also geographically assigned. So the physician groups had a notable incentive to move the needle on their own length of stay. And when given access to this data, they became very keenly interested in how they can create more capacity for their service, for their geographic units, just by learning more about data and taking advantage of opportunities that otherwise cause a delay. So now, taking the concept of a grouping variable and using the grouping variable as well as a filter. Say you filter hospitalist group or service A by MSDRG. So now we're looking at just the hospitalist group and we're looking at all of their DRGs. And just by glancing at color, we can see that some of their larger DRGs by category are performing a little less than, a little over the benchmark. You can see that with the pink. You can specifically see it in sepsis, which is zoomed in the upper left. And you can see that some of their DRGs are performing better than the benchmark. And those examples could be cellulitis, renal failure, other kidney and urinary tract diagnoses. All right. So some are doing better, some not so much. So you can then say, okay, well, I want to just drill into sepsis. So let's zoom into sepsis and see if we have a challenge by payer. And there you go. So it's not just all sepsis cases, it's the sepsis cases that are on a Medicaid plan. This data comes from California, so it's called Medi-Cal. And if we could make a meaningful intervention in the Medi-Cal population, we would create 88 new cases. There's your incentive, right? And we would reduce opportunity days by up to 715. This could be, just going to give a further example, it could be that a specific antibiotic that is desired for the treatment of these patients is not covered by the plan. So it could be discharge delays, barriers that you experience. You know, it may not just be as simple as saying, oh, well, it's Medicaid, so we just need to push harder. But instead, why Medicaid? Why in this case, is it one specific thing, or unfortunately, is it some of the systemic problems that we see with our Medicaid patients and our Medicaid population? But food for thought. It could be as simple as a high cost specific antibiotic that they are seeking to discharge these patients with that is holding up the process due to prior auth, due to denials, etc. News story. So again, California hospital. This is a children's hospital. A pediatric respiratory group was looking at opportunities. They wanted to improve pediatric bronchiolitis. The baseline length of stay, when averaged, was 3.8 days for this population. An intervention was made, and the post-intervention results was a length of stay on average 2.4 days. What did they do? So they used a dashboard, they used a tree map specifically, and they started by developing an understanding of their population. And they noticed that their largest group of patients, the largest presenting group of patients, are classified in the Latinx race ethnicity. And for that patient group, they are trending about 0.7 days over the predicted length of stay value. They noticed some opportunities in the Asian community. They also noticed that in the white or Caucasian, the Black or African American, and the other groups, they didn't really see that same length of stay challenge. So they began to unpack what could be causing these issues. They interviewed several families, and they engaged interpreter services for some assistance. It turns out that the discharge literature, the discharge packet that they give in pediatric bronchiolitis was really poorly translated into Spanish. And these families were not necessarily getting all of the education that they needed to be safe and sustainable at discharge. So they changed the way that they engage interpreter services early in the hospitalization. They did some training and they improved their materials. And here is the same group of patients after the intervention was made. So they very significantly improved those disparities that were originally present in race ethnicity. And just to lay the two side by side. Now, I would ask or challenge you, could this be an opportunity at your hospital? It may not be peds bronchiolitis, but send me a chat if you think that it could be that there, you look under the covers, right? That there could be an opportunity to consider race, ethnicity data and variables and tease out some like specific opportunities for improvement. Okay. We have hung in there for 54 minutes and we are continuing to run. This is learning objective 3, return on investment. So I want to introduce you to 4 patients. And being that I live in Southwest Virginia, they're going to have Southwest Virginia names. So here's Billy, and here's Rick, here is John and Ed. All right. So the cool thing about Billy, Rick, John, and Ed, they were admitted to the same hospital. They were placed in the inpatient status. They all are going to have sepsis. Okay, I'm just going to let the cat out of the bag. Very similar clinical and case presentation, fever, lethargic, anticipate sepsis. They're all within that 50 to 52-year-old bracket. So again, terribly similar patients, but I'm going to introduce a wrench, a little change in two of them. So now let's talk about sepsis DRGs. It's a good time to do that. Just a little segue. Knowing DRGs is tremendously important. I anticipate many on the call have a good, solid grasp of DRGs. Here are the sepsis DRGs that we're working with. And let's look at the predicted length of stay just using Medicare geometric mean length of stay and arithmetic mean length of stay as published in the 2024 final rule file. Okay, nothing crazy. So you can see that while DRG 870 gives you quite a lot of days because it's mechanical ventilation greater than 96 hours, DRG 871 and 872 just don't have that same time frame. 4.8 to 6.2 days, 3.5 to 4.2. Okay, so let's see what coding assigned to these 4 patients. So Billy and Rick have a 5-day or a 4-day length of stay. Good job. But John was here 8 days and Ed was here 7 days. So what could the difference be? Well, I noticed that John was admitted on a Thursday. Ed was admitted on a Friday. I don't know what day this fictitious hospital has switch day, and I also don't know if they were managed by a service that switches every 7 days, but that's sometimes a culprit. So this is our baseline data. We're not at the full ROI yet, right? So stay with me. What do DRGs do for us? So DRGs, they can level the playing field. They can give you a fairly straightforward, based on national experience, based on hundreds of thousands of claims across the country, or for a specific population if you have a benchmarking tool or software or vendor. They can give you those insights that, again, are diagnosis adjusted. They can look at comorbidities and other factors with similar diagnosis groups to give you that comparison. And most importantly, DRGs do lay the groundwork for a good benchmark opportunity. But here's the other thing. DRGs do not necessarily acknowledge family dynamics and a lack of a support system. They do not do a good job at weekdays versus weekends, and they don't acknowledge delays in a post-acute service such as home health. Okay. So John and Edward had delays. They had a delay connecting with family and a delay in DME delivery. So if we kind of push this narrative forward, if all 4 of our patients experienced a length of stay no greater than 5 days, then we'd probably be looking at an ALOS of 4.75. But because of John and Edward's delay, we're looking at an ALOS of 6 days. So this is going to be showing up pink or red in our tree chart because we have 2 cases that are pushing that average, one of the 3 amigos, pushing that average over what the benchmark would have called for. Okay. So now if we add up all the days and subtract from the total of benchmark days, our opportunity days in total across these 4 cases would have been 5 days, driven by John and Edward's experiences. So then the last statement really becomes the nexus of our ROI. If we had systems that were in place to manage those avoidable days, then we would have room for 1 more hospital admission. Pretty cool. All right. So if you have hospital data in front of you or at your disposal, let's walk through this together. ROI setups are fairly straightforward and fairly structured. So we start with your intervention. You need to create a statement that proposes, by doing this, so by investing in X, I'm going to reduce length of stay by X days. So in the chat, send in your proposed intervention. It could be that you want to hire one case manager to cover the weekends. It could be that you want to hire an administrative assistant. Maybe you want to invest in a piece of software. Whatever it is, send in what your intervention would be, and then forecast, what do you think, what do you anticipate, what does the data tell you that, whether it's benchmarking or historical experience, by doing this, by doing X, organizations reduced their length of stay by this much. So by purchasing ABC software, the organization saw a 5% drop in length of stay by 1 day, or whatever it was. Okay, so send in your ideas in chat. I would love to read them. My example is this: the hospital data in my made-up hospital has seen very small, we're not talking about the complex cases, we're talking, we seem to be losing a day. They should have gone on Monday, they didn't discharge till Tuesday. Story of our life, right? So the hospital has seen rather systemic, minor incremental delays. And the proposal is to adjust the staffing ratio by hiring an additional case manager. So the proposal is to hire an additional case manager, and the target that I'm going to propose in my fake hospital that we're going to hit is, if the hospital invests in this additional position, they're going to eliminate 12% of these 1 day extra situations, 1 extra day. So they're going to reduce length of stay for 12% of the population by just 1 day. We're only reducing by 1 day. Okay. So step 2, we're going to take that proposal, we're going to calculate an impact. So to do that, we ideally need to know, especially with my example, how many discharges do we have in 1 year? So in my example, I discharge 10,000 cases a year. And remember, all I said was that 12% of my hospital discharges will leave 1 day sooner. Now the math becomes really easy, so you are more than welcome to reuse this at your institution. So out of 10,000 discharges, I believe that I will reduce the length of stay for just 12 small percent of my total discharge population by 1 day. I don't want to do any more than 1 day. So that means that 12% of my 10,000 discharges is 1,200 discharges. Out of those 1,200 discharges, I propose that we're going to save just 1 day. So 1,200 days. All right. So move that needle forward. The population is 10,000 discharges. 12% is 1,200. And we're going to save 1 midnight. Okay. We're going to save 1 midnight. So we're going to save 1,200 days. Step 3. If we save 1,200 days, we probably need to adjust for inefficiency. Okay. What do I mean by that? Think about how long it takes for a bed to be cleaned in your facility between patients. Think about transportation times within the facility. think about pull times to bring a new patient from the ER up to that bed. If we're going to discharge patients 1 day faster, we're going to be generating more bed turns. The bed in the hospital is going to turn over more frequently. We need to build in a little bit of inefficiency to make that bed turn happen. So to do that, what we need to look at is perhaps a 5% reduction. I'd say if you want to stay safe and stay off the CFO's radar, do a 10% reduction. So we're going to say that inefficiency is 10%. Okay. So I proposed 1,200 days. Inefficiency is going to remove 120. So that means that I have 1,080 days to work with. Okay, cool. So 1,200 saved days. I'm going to subtract inefficiency, which is 10% in my example. And I'm going to have 1,080 days that I have saved that I can now use for new patient population. I'm going to take an average length of stay of 5 days, and I'm going to divide it into 1,080. And that gets me 216. Okay. 216 is the proposed quantity of additional admissions that I can generate. I accomplished that by taking my 10,000 patient population, applying my 12% rule to it, and you can assign whatever percentage you feel makes the most sense based on the intervention you're making. And out of my 10,000 discharges, I'm only going to save 1 day for 12% of them. So that's 1,200 days. I take my 1,200 days, I reduce for inefficiency because we're going to have more bed turns. So I have 1,080 days that I can work with. I take my 1,080 days and I divide it by my typical hospital length of stay. And I get 216 more admissions. What is the margin or the revenue that your hospital typically sees for an admission? You now take that revenue or that margin, the CFO really, or his designee or her designee really should get involved at this point and give you a figure that they're comfortable with you leveraging in your narrative. But in any event, the CFO says, okay, well, revenue per admission is 35,000. So just use 35,000. So you take 216 and you multiply that by 35,000. And then you take the cost to add the positions you want. In this case, 4 case managers, 2 social workers. You say the investment I'm asking for is 615,000. The return prior to equity or prior to paying the bills is 6.9 million. That is how we do an ROI for length of stay. Now, this 4-step formula can be applied in a variety of ways. You might instead propose that you are going to reduce the amount of time that cases wait to go to a post-acute. You're still reducing length of stay, but you might just be saving cost. You can also ask the CFO, what is the daily cost of a bed? The typical daily cost of a bed, because we're still giving those holding patients medications. We're still giving those holding patients nursing care. We're always going to keep the lights on. So fixed versus variable cost has a role to play here. But to really break it down in the most simplistic terms, if we're going to get patients to a post-acute setting quicker, sooner, faster, we are going to save length of stay. So you can approach this from a revenue generation perspective, but you could also approach it from a cost savings perspective. You could say, okay, we know that our cost per day is about $1,000 on med surg. So $1,000 on med surg. And you could also say at the end of the hospitalization, my cost per day might be a little bit less. So I can adjust that down. Take your cost per day, multiply it by the quantity of days that you're going to save, and propose that instead of creating new admissions, you're just going to save cost. You're just going to control that cost that occurs when patients stay longer. All right. We've navigated our 3 learning objectives. I certainly hope you had fun during that presentation. We have about 20 minutes for questions and comments. So, Adam, I'll turn to you to help me out.
No problem. Just so folks know, I loved your calculation there at the end in particular. I just put into the chat. We did a calculation amongst our staff using kind of baseline data and cost data in terms of the fixed cost of just housing patients in our facilities and continuing to take care of them for those who are waiting discharges to post-acutes. And I think the number we came up with was $400 million across both, because there's a little variation between med-surg beds and ICU beds, but we're able to calculate that cost. So it was fascinating to see the size of the challenge. And other states have done that as well. Other hospital associations in other states have done that calculation where we've looked at what do those costs look like. And so it's a great example of how you can effectively use data to kind of really share with the broader community what the challenge is and the costs that hospitals are incurring because we do not have the capacity across our system.
Absolutely.
So Karen put into the chat, she asked, they're interested in evaluating an ambulatory care management program. Do you have any examples on how to evaluate the impact on cost or utilization? Should they use readmission rate, ER visits, on improving performance on risk contracts?
So a lot of times with ambulatory programs or the pop health programs, if you have it, one of the big barometers is PMPM, which is the per member per month spend. And that's just one example of looking at cost and utilization specific to your members. But not all programs have that. So to Karen's point, I would then say readmissions, great suggestion. Emergency room visits, another fantastic suggestion, especially looking for that recidivism pattern or highly reoccurrent events. The third suggestion I would make is outpatient appointment compliance. So I'll give you a numerator denominator example. Patient X had 10 appointments created, 7 appointments kept. So sometimes in these populations we're managing, we're trying to look at or encourage the importance and the significance of access to an ambulatory care space or their understanding of the importance of seeking care. So the third suggestion I would have is looking at appointment compliance, whether it is for specific appointment types or all.
Awesome. Thanks, Jeff. Just a call out to anybody out there right now. If there are any further questions that anybody has for Jeff, please feel free to either jump in or enter them, preferably enter them into the chat. Checking the chats right now. I don't see any additional questions in the chat at this time. Jeff, if folks want to reach out to you with any questions or concerns, what's the best way to get a hold of you?
So the best is to send me an email. Adam, I can't remember, is my email accessible to the members?
Why don't you pop it into the chat right now if you have the chance? Might be easiest for folks to do.
I spelled it right. All right, there you go.
Awesome. Thank you so much again. Really appreciate it. Any other questions one more time before we take leave of Jeff here today? Really appreciate it. Loved the data, loved the presentation, loved the presentation and the suggestions and recommendations with regards to the type of charts you should be using too, because those charts that you mentioned that can be generated pretty easily, in Excel are very convenient. However, thinking a little bit more critically about how you want to present that data is really important.
Yep. Got to tell a story.
That's right. All right. Seeing no further. Oh, wait, hold on one second. Karen actually followed up on her original question. She asked, what could you use for benchmarks for readmission rates and costs?
So with readmits, the first thing you have to consider is if the return visit will be rolled in under the primary visit and therefore not paid for in total. So we see that a lot. That's not a unilateral occurrence. There are coding standards that would have to be applied, or the payer, whether it's a commercial or managed plan, would sometimes propose. Your key thing to look for in that circumstance, and this gets directly at cost benchmarking, is when and heart failure is my favorite example. When the initiating DRG is in the same family as the return DRG. So if you have a heart failure DRG on your first visit and a heart failure DRG on your second visit, and you're within the 30-day window, there's a pretty good chance that your second visit is going to be considered a merged visit after a leave of absence, and you're not going to get paid exclusively for the second visit. So in terms of how do you assign benchmarking to that, you would identify the population of cases that are having a payment reduction specific to returning for the same reason. And you would then propose, here is an option one. Let's say that in 1 year, the hospital experiences 500 occurrences of this readmission phenomenon where they were DRGX and they come back with DRGX. Okay, so 500 occurrences in a year. What's the ALOS for the return visit? Pretend it's 5 days. So 500 occurrences, 5-day length of stay. We would want to try to prevent all of those. Now, we know we can't, but we would want to try to prevent all of those. So you would then start with a narrative. If I can reduce 500 returns to 250 returns, as an example, what amount of hospital bed space would I create? That's option one. Second option, what cost reduction? Again, you're not getting paid for these. In this example, you're not getting paid for the second visit. So what is the average hospital cost, not the reimbursement, but the cost per visit? Multiply the quantity of visits you're seeking to prevent by the cost per visit. And that gives you a cost metric that you can make an intervention on. So those would be a great example. It does get Karen, it gets a little bit harder when you are working with abstract figures. And to me, the Medicare payment penalty is a bit more abstract. It's certainly there, but it's a bit more abstract. You typically have to kind of peel back several layers of the onion if you're in a payment penalty under a readmission program under Medicare. I kind of like the more direct numerators and denominators, the dollars and cents, but ultimately you've got the payment penalty as an option if your quantity of readmissions is above the national average for a specific reporting category. You've also got the opportunity to look very specifically at those cases that are returning with the same DRG family within a specific time frame.
Thanks, Jeff.
I did
All right.
see.
What? Go ahead.
I saw one more question that was a bit more about graphs. I believe it is. is that Michelle possibly? So the question was, is this a specific program that allows for tree maps with drill down? Fantastic question. Um, the screenshots that I used were collected from a product called Tableau. Tableau is a really well-known data and statistics platform, but I would call out that pretty much in air quotes, all of your major dashboard platforms, and this is in terms of the dashboard delivery tool, right? So Power BI, Tableau, Tabico Spotfire, Click, which is QLIC, they all typically or generally offer a tree map as an option. Excel, I think, actually just recently introduced in its native functionality a tree map. Newer to Excel, I will disclose that. But pretty much all the major players offer that. What you would have to focus on for your hospital is working with analysts or BI developers or your data engineering staff, which of course that's kind of my background, right? Which gets me excited. But you would have to work with the appropriate staff to build a data set. Sometimes we call that a data mart that sits behind that dashboard to facilitate the click and drill, which I think is imperative for case management programs. But fantastic question on the graphs I used today.
Yeah. So Karen has one additional question that I do want to throw out as well. And Karen asks, do you have any strategies for how to determine if care management interventions are impacting utilization?
Good question. I would go back to PMPM because per member per month spend is going to have a pretty good barometer on what the spending looks like for that category. So if you're tracking a specific group of patients that might be quote unquote enrolled in a pop health program, you would look at your enrollment basis and you would make an intervention and then you would trend the PMPM in the months or years that followed.
Okay. Thanks, Jeff. Any additional questions for Jeff? All right. Since we are coming up against time, it doesn't look like there are any more questions coming in through the chat. I just want to again thank you, Jeff, for leading a great session today. We really do appreciate it. And really thank everyone for joining us here today on our call. We are going to have a number of new educational events that are coming up. So we have a number of events, including our September 10th Substance Use Disorder and Harm Reduction Conference. That's going to be in person here at the MHA Conference Center in Burlington. And if you are interested, you can scan the QR code on your screen now to see all of MHA's educational programming. As we said, we have several events that are coming up this fall, a couple even next week as part of our case management series on August 5th with regards to health equity. And you can join Marissa Glover from the Center for Case Management for that event as well. We hope to see you all again very soon. Please don't hesitate to reach out to myself or Sarah Ramon here at MHA with any questions or concerns with regards to any educational programs. Thank you so much and have a great day.